Hey everyone! Today we're diving into the crucial topic of handling emergencies in the medical field. We're talking about D25W, or 25% dextrose in water. This hypertonic glucose solution is a powerful tool in emergency medicine. For severe hypoglycemia, especially if the patient is unconscious, having seizures, or unable to take oral glucose, D25W can be a lifesaver. It's essential when seconds count and the stakes are high, but with great power comes great responsibility. D25W is not a simple saline drip. It's a potent medication that requires precision. Misuse can lead to serious problems, sometimes as dangerous as the condition being treated. It's a medical double-edged sword where the line between therapeutic and harmful is fine. We'll break down the risks, what they mean for the patient, and how to mitigate them. Understanding these pitfalls is what separates good practice from great practice. It's about ensuring we do more good than harm. So grab your notebooks, get comfortable, and let's dive into the critical details of D25W. First up, let's talk about the immediate, local effects of D25W. Imagine trying to push a thick, sugary syrup through a very delicate, small tube. That's essentially what we're doing when we administer D25W through a peripheral vein, like one in the hand or forearm. This solution is what we call hyperosmolar, meaning it's much more concentrated than our blood. This high concentration is incredibly irritating to the inner lining of the veins, the endothelium. The body's natural response to this irritation is inflammation, a condition we call phlebitis. The patient will feel it as pain, redness, and swelling along the path of the vein. It's not just uncomfortable. It's a sign that the vein is under stress and getting damaged. Now, what happens if that stressed vein gives way, or if the IV catheter accidentally slips out of the vein? This is a situation called extravasation, and with D25W, it's a big deal. The solution leaks into the surrounding subcutaneous tissue, and because it's so concentrated, it acts like a chemical burn from the inside out. It can cause severe pain, blistering, and in the worst cases, tissue necrosis, which is the death of tissue. This isn't just a minor complication. It can lead to permanent scarring, loss of function, and may even require surgical intervention to remove the damaged tissue. This is why meticulous IV placement and constant monitoring of the site are not just best practices. They are absolutely non-negotiable when you're using a solution this potent. Think of it this way. A peripheral IV line is like a small local road, not built for heavy industrial traffic. D25W is the oversized, heavy-duty truck. Pushing it through that small road is going to cause damage to the asphalt and create potholes. If that truck veers off the road, it's going to tear up the surrounding landscape. The risk of phlebitis and the danger of extravasation are the primary reasons why we have to be so incredibly careful with where and how we administer D25W. It's a constant balancing act between the need for rapid glucose delivery and the protection of the patient's vascular integrity and surrounding tissues. Every drop has to be accounted for. We use D25W to correct low blood sugar, but what happens if we give too much or give it too fast? We swing the pendulum in the complete opposite direction, causing iatrogenic hyperglycemia. That's a fancy term for high blood sugar caused by medical treatment. The goal is to bring a patient from a dangerously low level back to a normal range, not to send them skyrocketing into a dangerously high one. When blood glucose levels spike rapidly, the body is thrown into a state of acute metabolic stress. This isn't a benign state. It comes with its own set of symptoms and risks that can be quite distressing for the patient and complicate their overall clinical picture. Patients experiencing this sudden hyperglycemia might start complaining of a pounding headache, blurred vision, or an unquenchable thirst, a symptom we call polydipsia. Their body, trying to get rid of the excess sugar, will ramp up urine production, leading to frequent urination, or polyuria. This isn't just an inconvenience. It's the beginning of a dehydration cycle that can have serious consequences, which we'll discuss more in a bit. Essentially, by trying to solve one problem too aggressively, we've created another. We've overloaded the system's capacity to handle glucose, and the patient's body is now working overtime to try and restore balance, putting a strain on multiple organ systems in the process. This is why dosing D25W requires careful calculation and consideration of the patient's weight and clinical status. It's not a one-size-fits-all medication. After the initial dose, it's critical to recheck the blood glucose level frequently. We need to see if we've hit our target, or if we need to give more, or if we've overshot the mark. It's a process of titrating to effect, making small, calculated adjustments rather than just pushing the whole syringe and hoping for the best. Managing hypoglycemia with D25W is a delicate dance, and avoiding the rebound spike of hyperglycemia is a key step in leading your patient back to safety without introducing new dangers along the way. Beyond just sugar levels, the administration of a large, concentrated glucose load has profound effects on the body's electrolytes, particularly potassium. This is a critical point that can sometimes be overlooked in the heat of an emergency. When we push a bolus of dextrose, the body releases insulin to help move that sugar from the bloodstream into the cells. But here's the catch. Insulin doesn't just move glucose. It also co-transports potassium into the cells along with it. This causes a rapid shift of potassium from the extracellular fluid, the blood, into the intracellular space. The result? A sudden drop in the serum potassium level, a condition known as hypokalemia. Why is this so dangerous? Potassium is absolutely vital for the normal function of our nerves and muscles, and most importantly, the heart muscle. The heart relies on a precise balance of potassium inside and outside its cells to maintain a regular rhythm. When blood potassium levels plummet, it can destabilize the heart's electrical system, leading to dangerous arrhythmias or irregular heartbeats. In a patient who is already critically ill, or someone with pre-existing heart or kidney disease, this sudden drop in potassium can be the tipping point that leads to a life-threatening cardiac event. It's a silent but deadly complication that we must anticipate. This risk is even more pronounced in specific patient populations. For example, a patient with diabetic ketoacidosis, or DKA, is already often potassium depleted, even if their initial lab values look normal. Giving them a large glucose load without carefully managing their potassium can be catastrophic. The same goes for patients with renal failure, whose kidneys are unable to regulate potassium effectively. This is why monitoring electrolytes, especially potassium, before and after giving D25W is not just a suggestion, it's a fundamental safety requirement. We might need to supplement with potassium intravenously at the same time to prevent a dangerous dip. It highlights how treating one number on a lab report, glucose, requires a holistic view of the patient's entire physiology. Let's circle back to that high blood sugar spike we talked about earlier. When the concentration of glucose in the blood becomes excessively high, it overwhelms the kidney's ability to reabsorb it all back into the body. Think of the kidneys as having a specific filter threshold for sugar. Once the blood sugar level crosses that threshold, the excess glucose starts spilling over into the urine. This isn't just a simple waste product, though. Glucose is an osmotically active particle, which means it pulls water along with it, kind of like a sponge. This process is called osmotic diuresis, and it's the body's emergency mechanism for getting rid of excess sugar. The consequence of this is a significant loss of water through urine. The patient starts urinating frequently and in large volumes, as we mentioned before. But it's not just water they're losing, they're also losing essential electrolytes along with it. This can quickly lead to dehydration, even while the patient is receiving IV fluids. The signs can be subtle at first, dry mouth, increased thirst, but can progress to more serious symptoms like a rapid heart rate, dizziness, confusion, and a drop in blood pressure or hypotension. In an already unstable patient, this fluid shift can be enough to tip them into hypovolemic shock. We're essentially creating a paradox. We're giving intravenous fluids, yet the patient is becoming dehydrated. It's a direct consequence of the hyperglycemia induced by the D25W. This underscores the importance of not just monitoring blood glucose, but also paying close attention to the patient's overall fluid status. We need to be tracking their urine output, checking their blood pressure, and assessing for clinical signs of dehydration. If we've caused significant hyperglycemia, we may need to administer additional IV fluids, this time without dextrose, to replace the volume that's being lost through osmotic diuresis. It's a reminder that every intervention has a cascade of effects, and our job is to manage the entire cascade, not just the initial action. Now we need to discuss a very specific high-stakes scenario, the patient with a brain injury. This could be someone with a traumatic brain injury from an accident, a stroke, or any other condition that causes swelling in the brain, also known as cerebral edema. In these patients, the brain is in an incredibly fragile state. The skull is a fixed box, so any swelling increases the pressure inside, known as intracranial pressure or ICP. This increased pressure can compress vital brain structures and reduce blood flow, leading to further brain damage. It's a neurological emergency, and our primary goal is to reduce that pressure. Here's where D25W becomes particularly hazardous. When we rapidly infuse a hypertonic solution like D25W, we create a rapid shift in the osmotic gradient of the blood. Initially, this might seem like a good thing, as it can temporarily pull fluid out of tissues. However, the glucose is quickly metabolized by the brain cells. What's left behind is a large volume of free water from the D25W solution. This free water can then cross the blood-brain barrier, which is often already damaged and leaky in these patients, and move directly into the brain tissue. The result? A rebound increase in cerebral edema and a dangerous spike in intracranial pressure. Essentially, by trying to correct their blood sugar, we could be inadvertently worsening the primary neurological injury. We could be fueling the fire we're trying to put out. This is why in patients with known or suspected intracranial hypertension or cerebral edema, the use of D25W is often contraindicated or must be approached with extreme caution. We might opt for a more concentrated solution like D50W in a smaller volume to minimize the free water load, or explore other methods to manage their hypoglycemia. It's a critical consideration that requires a deep understanding of neurophysiology. In these cases, a simple blood sugar correction is anything but simple. It's a complex decision that weighs metabolic needs against neurological risks. We've already established how irritating D25W is to small, peripheral veins. That constant irritation and inflammation, the phlebitis we discussed, can lead to a more serious complication, thrombophlebitis. This is where the inflammation of the vein wall actually triggers the formation of a blood clot, or thrombus, at the site. The vein becomes hard, cord-like, and extremely painful. Not only have you lost that IV access site permanently, but you've now created a blood clot that could potentially cause further issues. While usually localized, it represents a significant failure of that vascular access. The risk doesn't stop there. If a clot forms in a larger vein, or if the irritation is significant enough, it can lead to a deep vein thrombosis. This is a much more serious condition, as pieces of the clot can break off, travel through the bloodstream, and lodge in the lungs, causing a pulmonary embolism, a potentially fatal event. While this is a rarer complication from a peripheral D25W infusion, the underlying principle is clear. Introducing such a caustic substance into smaller vessels is inherently risky and invites the body's clotting cascade to get involved. We are essentially provoking the vein into forming a clot. This is why, for patients who require repeated or continuous infusions of hypertonic solutions like D25W, the standard of care is to use a central venous catheter, or a central line. A central line is a larger catheter placed into a large, high-flow vein, such as the subclavian, internal jugular, or femoral vein. The tip of the catheter sits in the superior vena cava, right near the heart. When D25W is infused through a central line, it's immediately diluted by a massive volume of blood, minimizing irritation to the vessel wall and drastically reducing the risk of phlebitis and thrombosis. It's like pouring a small amount of syrup into a rapidly flowing river versus a stagnant pond. The river dilutes and disperses it instantly. Whenever possible, a central line is the safest highway for delivering these potent solutions. So as we've seen, D25W is an incredibly effective tool in our emergency arsenal, but it's one that demands our utmost respect and attention to detail. It's not a medication to be given lightly. The key takeaway here is vigilance. From the moment you decide to use it, you need to be thinking 3 steps ahead. The first step is always assessing the access. If the patient is going to need ongoing treatment, or if you have any doubts about their peripheral veins, advocating for a central line isn't being difficult, it's being safe. It provides the safest route for administration and protects the patient from the painful and dangerous complications of phlebitis and extravasation. Next, it's all about the monitoring. This isn't a push-it-and-forget-it drug. We need to be glued to the glucometer, checking levels frequently to ensure we're hitting that sweet spot, not too low and certainly not too high. At the same time, we have to keep a close eye on their electrolytes, especially potassium, and be ready to replace what's lost to prevent cardiac complications. And don't forget to watch the patient themselves. Are they becoming dehydrated from osmotic diuresis? What's their blood pressure doing? A holistic assessment is crucial to navigating the potential systemic effects of D25W. Ultimately, using D25W safely is a testament to good clinical practice. It's about understanding the pharmacology, anticipating the risks, and monitoring your patient with unwavering diligence. Always watch that IV site like a hawk for any signs of redness, swelling, or pain. By respecting the power of this solution and adhering to these safety principles, we can continue to use it to save lives while minimizing the potential for harm. It's what our patients deserve. Thanks for watching, stay curious, and I'll see you in the next video.